So good afternoon, everyone. For those of you on the East Coast and in the Midwest, for those of us still on West Coast time, it's still morning. We certainly want to thank you for joining us in lieu of the challenging weather, and I extend that to Dr. Terplan as well. He's having quite a bit of snow in the Baltimore area. So welcome to our next webinar. For those of you who joined us last month, you know that we got to listen to Dr. Andre Jones, and actually Dr. Jones and Dr. Terplan are colleagues, and she recommended him for this particular webinar. So we're really grateful to have that connection and certainly grateful that he could join us. Before he starts, I just want to give you a couple of reminders. We have a chat log on your screen. We hope you've all joined on the webinar link, and so you should be able to see a box on the right-hand side, and there's a chat log. Should you have questions, because you're all on mute, you can go ahead and type them into that chat log, and we will be monitoring those questions throughout his presentation. We're going to open it up at the end, and we'll go through those questions, and he'll have a chance to respond to you. And we'll also open up the mics, and you can ask any questions at that time. Should we run out of time or not get through all the questions, we'll certainly go through them afterwards and send you responses. I want to thank Dr. Nancy Young is on the line. She's on mute as well for joining us, and it's actually Dr. Nancy Young and our Federal Projects Officer, Sharon Amatetti, who have really spearheaded this effort over the last couple of years. I believe that Sharon Amatetti is on a different call this morning and was not able to join us. So certainly much appreciation to both of them. And Dr. Young, you have any comments or questions during the course of this, please let us know, and we'll open up your phone. So, all right, let me start again first expressing our appreciation to Dr. Terplan for being available today. He is the Medical Director for Behavioral Health System in Baltimore. He completed his medical degree at the University of California, San Francisco, and his residency in obstetrics and gynecology at the University of Southern California, Los Angeles County Hospital. After that, he completed his training in epidemiology and clinical trials fellowship at the University of North Carolina, Chapel Hill, where he obtained a master's in public health and epidemiology. He's board certified in both obstetrics and gynecology and addiction medicine. Prior to coming to Baltimore Health System, he was on faculty at the University of Chicago and more recently at the University of Maryland. His clinical work and research is focused on the intersection of reproductive health and addictions, which makes him really excellent for us with this particular webinar. So, Dr. Terplan, I'm going to turn it over to you.
Okay, well, thank you very much. Thanks for inviting me. Thank you, everyone, for listening. And thanks for those of us in the Midwest and East Coast for persevering through what feels like an endless winter. So I'm going to begin really by talking about the natural history of substance use in pregnancy. I'm going to talk about screening, brief interventions, and SBIRT, which stands for Screening, Brief Intervention, Referral to Treatment, how you integrate that into practice. We'll talk a little bit about when and how treatment happens, and this is going to be illustrated with some case examples. Before I get into the natural history, I wanted to just clarify some terminology. The field of addiction is replete with a multiplicity of different terms, and these terms have gone in and out of fashion to a certain extent. The terms that I really am going to use for this talk are substance use, which means anyone having used a substance within a recent period of time. And the point is that use doesn't equal problematic use or a use disorder. Some individuals who use substances will have a substance use disorder, which is a clinical criteria. And addiction is very similar to a substance use disorder, more from the Society of Addiction Medicine perspective, but is seen as a chronic brain disease with relapsing periods of abstinence, periods of relapse. Terms that I avoid are actually substance abuse, although this was more recently in fashion, mostly because there's a pejorativeness to the abuse part. Similarly, the term addict, we shouldn't be describing people by their illness states for behavioral health conditions in general, as well as actually somatic conditions. Two things that I'm not going to discuss but do come up sometimes as questions is this idea of tolerance and this concept of dependence. Both of these are physiological sort of responses to substance use. Tolerance being that in order to achieve a psychoactive effect of a substance, the dosage needs to be increased over time, and dependence is sort of the inverse of withdrawal, so that means that the absence of the substance leads to some sorts of measurable biological states. The important thing really is that neither tolerance nor dependence, although those are part of the diagnostic criteria for an addiction or like a substance use disorder. So pregnancy is actually a really interesting period of time to look at substance use. In part because almost all pregnant women have access to medical insurance. They have increased contact with social and medical institutions. And it's also a window of opportunity for behavioral change, as you'll see with the data coming up. In many ways, when we talk about substance use in pregnancy, what we're talking about is where reproductive life course and substance use or addiction life courses intersect. There's no woman who initiates a substance use disorder during pregnancy. Women who use substances during pregnancy are women who use substances before they got pregnant, who get pregnant, who continue to use. So this is the first case. LP, she's a 28-year-old G2P1, that stands for Gravida2 Para 1, which means she's been pregnant twice, including this one, and she's had one prior delivery, who presents to the emergency department with nausea and vomiting and found to be pregnant. Her pregnancy is unplanned but desired. She drinks more than 10 drinks a week with binge almost every weekend and occasionally smokes marijuana. So the first question I have, I'm not going to answer it, is what can we expect her substance use, if she continues her pregnancy, what's going to happen to her substance use? Is she going to stop smoking the marijuana but keep drinking? Stop both drinking and smoking? Stop the drinking but keep smoking? Or neither stop drinking nor smoking? So what I'm going to talk about now is what happens when women who use substances get pregnant. And in many ways, pregnancy is this natural experiment in behavioral self-change. There's two different ways that we can answer this question, what happens when women who use substances get pregnant. One is we can compare pregnant women to non-pregnant women by their substance use. And that's what we see on this slide. These data are coming from the National Survey of Drug Use and Health. It's an annual survey that's administered by SAMHSA, and it is a weighted sample of all non-incarcerated individuals in the United States. There's a whole bunch of questions that are asked. It's anonymous. It's de-identified. It's thought to be as close to a gold standard of substance use as we have. I've just sort of split these years here just so you can see that there's really very little difference across time, and stratified by pregnant versus non-pregnant. This is just looking at alcohol. So we can see non-pregnant, about 55% of women say they currently use alcohol, and that's defined as last 30 days. So they say, yes, I had a drink in the last 30 days. And that contrasts to about 10% of women who say, yes, I'm pregnant, and yes, I had a drink in the last 30 days. Binge drinking, which is defined for women as 4 or more drinks in one sitting. About 25% of non-pregnant women report binge in the past 30 days, compared to only 2% of pregnant women. And heavy drinking, which is defined as binge on at least 5 days in the past month. About 5% of non-pregnant women said that they binged, or that they had heavy drinking. So they binged 5 or more times in the past month, compared to, about 0.5% of non-pregnant women. When we look at cigarettes, we see a similar sort of pattern, that non-pregnant women smoke more than pregnant women. One thing to note, though, is that this curve of pregnant women has decreased more significantly over the past decade than the proportion of pregnant women who report past month cigarette use. And in fact, from hypothesis testing, there's no difference across this line of pregnant women. For illicit substances, similarly, we see that pregnant women report less use of illicit substances. About 11% of non-pregnant women say, yes, they used an illicit substance in the past 30 days, compared to about 5% of pregnant women. Although this appears to be an increase amongst pregnant women from 2002 to most recent hypothesis test, there's not a P for trend that's significant across this. So one thing that we can say from looking at the data this way is that compared to non-pregnant women, pregnant women, I guess I missed that, drink less alcohol, smoke fewer cigarettes, and use fewer illicit drugs during pregnancy. Another way that we can look at how substance use changes through the course of pregnancy is by stratifying by trimester. If you remember that from alcohol, about 50% of women, non-pregnant women, said they used alcohol in the past 30 days. About 20% said that they used, in their first trimester, had used alcohol in the past 30 days, and it decreases from the second to the third trimester. Similarly for cigarettes, about 20% of pregnant women who are in their first trimester say that they smoked cigarettes in the past 30 days, and that decreases, although not as much, in the second to the third trimester. And illicit drugs, about 11% of pregnant women, non-pregnant women used an illicit substance in the past 30 days. 9% of women in their first trimester say they used an illicit substance in the past 30 days. It decreases to 5 amongst those in the second trimester, and to a little more than 2 in the third trimester. What about postpartum? And really for this slide, just focus on this dark thing up here, because it's a great article, but it flips the script in that this is the proportion who abstained rather than the proportion who used. But amongst women who used an illicit drug immediately prior to or in early pregnancy, about 24% remain abstinent in the postpartum period. For cigarettes, it's a little bit less. About 16% of people remain abstinent, and same with alcohol. So to sort of summarize this, when women who use substances get pregnant, they drink less alcohol, smoke fewer cigarettes, and use fewer illicit drugs. Their use decreases through the course of pregnancy by trimester. And what we see is actually the greatest reduction in use happens early in pregnancy. Happens, if we just go back up and look at this, you can see the magnitude of change here is far greater than subsequently. And that's true for all the substances. People cut back on alcohol far more than they do on cigarettes, and illicit drugs is sort of in the middle. About 80% of women who use substances who get pregnant resume use postpartum. And this is one of these points that I hear a lot from providers, that it doesn't really matter what we do, 80% are going to go back to using. And this is an example of when I, again, like to flip the script. Actually, 20% of people are abstinent postpartum, and all we've done, the only intervention has been her pregnancy. And the 20%, as a treatment outcome, most of these women weren't in treatment, is actually really quite successful from a public health perspective. So I don't know if the audience is familiar with this, but there's going to be several slides around this idea of a risk pyramid. And one of the reasons to ask people about use is that it helps us organize their use into a pyramid of sorts. And the reason for this is like where you are in the pyramid guides your intervention. If we think, really where these lines are varies by substance and stuff. But generally speaking, most individuals are either don't use a substance or use at a very low risk level. That means the likelihood of them having, medical sequelae to their use or developing a use disorder is low. There is a proportion of people who have risky use. They don't meet criteria for a substance use disorder, but they're drinking alcohol, they're binging periodically, they're blacking out, they're putting themselves at medical and sort of behavioral health risks by their use. And then there's a smaller proportion of people who actually meet criteria for a substance use disorder for whom treatment is recommended. This is another way to look at it. This is from the ONDCP, which is the Office of the National Drug Control Policy, which is the drug czar, part of the White House. Here, you can see they're using terms that are a little bit different than what I use, i.e. dependent use, but regardless, about 4% of people, when you query them, especially for alcohol, will actually meet criteria for a use disorder and need treatment. About 25% will be using at higher risk levels and would benefit from a brief intervention. And then everybody else is using at a lower level, and for them, we screen them. So this slide is from Tom McClellan when he was at the ONDCP, and it's another way of conceptualizing this risk pyramid in terms of substance use. You can see he uses abuse. These terms are slide differently across different people. Sort of like the public health burden of substances. There are about 2.3 million people in the United States who are in drug treatment. According to the National Survey of Drug Use and Health data, there are about 25 million who meet criteria for a substance use disorder and really need treatment. And there are about 68 million who use at that higher risk level of use, who would benefit from early intervention or a brief intervention. And then everybody else is using at either not using or using at low levels and low risk. So what's interesting is that this category is huge. And this is actually with the ACA, with the integration of behavioral health into somatic care, with changes in reimbursement, with parity legislation. We actually have the medical structure to ideally properly address this large proportion of citizens. I don't know if all of this has come out through the prior data slides, but in my experience in taking care of women with substance use and substance use disorders during pregnancy, I can say that all pregnant women are concerned for their health and the welfare of their child-to-be and of their families. And actually all women are aware of risks associated with substance use, and actually all employ a range of strategies to reduce or change their intake. Many, as we saw, decrease or stop use. Some switch drugs. And when I first started in all of this, it was rare but not uncommon for me to take care of somebody who had used cocaine prior to her getting pregnant. She got pregnant. She was, terrified of the effects that cocaine might have on her fetus, and so she would drink alcohol as a way to sort of self-medicate for what the cocaine was doing. Alcohol being arguably a worse substance from a fetal perspective than cocaine, so that was, a non-beneficial harm reduction strategy. Now I see a lot of women who might have been using other non-marijuana illicit substances, using marijuana during pregnancy as a way to kind of switch use to something that's perceived as safer. Women also enter prenatal care as a way to sort of improve their health, and also enter substance use treatment. So now I'm going to talk a little bit about prenatal care, what it is, what we screen for, how substance use screening can fit into that, and sort of strategies. So first, another case. This is a 24-year-old G3P1. That means including this pregnancy. This is her third pregnancy. She's had one delivery. She comes at 17 weeks for her first visit. She was scheduled earlier, but she missed her prior appointment because of transportation difficulties, and her last pregnancy was complicated by a preterm delivery at 30 weeks. So the question is, should she be screened for substance use, and if so, why? She should be screened because she's late to care. She's not adherent with prior visits. She has a history of a preterm delivery. Depends what the urine toxicology shows. All patients should be screened, or she shouldn't be screened. So prenatal care, there's a lot of screening that happens in it. Recently, now it's been maybe 5 years or so, ACOG recommended offering cystic fibrosis screening to all white patients. The cystic fibrosis is rare, as you see from this. We do universal screening for HIV, which is thankfully still pretty rare. Birth defects, which would be either through the quad screen or early screening and ultrasounds, about 2% of births are birth defect. Anemia, we screen everyone for that. In some ways, prenatal care is one giant screening test for preeclampsia, because the two things that we do at every visit are blood pressure and checking urine for protein. And the frequency of prenatal care visits increases as gestational delivery date approaches, and all of that is around trying to catch people who might be at risk of developing preeclampsia. And that's about 2 to 8% of births will be complicated by preeclampsia. Everyone gets screened for gestational diabetes, and within the last 10 years we have really pretty close to universal screening for postpartum depression, which is common, 10 to 15%. So these are all things that we screen for now routinely. And you can see, comparing the prevalence of these disorders with substance use, substance use is as common, if not more common, than things we routinely screen for. So for those of you who answered the last case as everyone should be screened, you're correct. Universal screening for substance use is recommended during pregnancy. It's recommended by the American Academy of Pediatrics, ASAM, ACOG, etc. And this includes alcohol as well as prescription opioids. What is not recommended is selective screening based upon quote-unquote risk factors, i.e. somebody who is late to care, somebody who is had a poor birth outcome, somebody who meets your stereotyped idea of what a drug user is. All of that is wrong and unethical. It's going to miss most people who use substances, and it's going to perpetuate stigmas and stereotypes. And the reason for screening is really that early identification of substance use allows for early interventions and treatment for those who need it, which actually minimizes the harms to both the mother and her pregnancy. So how to screen? The big picture is asking questions in a caring and non-judgmental manner and normalizing it, embedding questions about substance use in other health behavior questions. Preface what you say by stating that you ask all your patients about substance use, so that the individual, she doesn't feel singled out because of whatever to be asked that question. It's also really important to ask permission. Is it okay if I ask you some questions about smoking, alcohol, and other drugs? And you really want to avoid closed-ended questions, such as, you don't smoke or use drugs, do you? So I think everyone on the call knows this, but substance use, is correlated with certain complications, negative health outcomes for women and their children. This is especially true for tobacco and alcohol, partially because there's more literature on it, partially because these are more harmful substances from a fetal perspective. I'm going to talk a little bit more about the second point, but it's important to also acknowledge and recognize that there's pregnant women who continue to use drugs are highly stigmatized, and by that I actually mean discriminated against by the healthcare system. And some of that, the fear they have about disclosure, is a real fear. There's been a lot of change in state legislation in terms of reporting requirements, etc. And there is a legitimate fear of legal ramifications for disclosure of drug use. All of this means that the context of asking questions needs to be as caring and non-judgmental and safe as possible. So in terms of instruments, an instrument would be either a piece of paper or on a computer or something that you either complete with the patient or she completes herself. They there are, I can't remember the last time I looked, let's say 100 different substance use screening instruments in general, of which only a small handful have actually been validated or among pregnant women or developed specifically for pregnant women. This is a small list of some of them. And really the question is, like, what is the benefit? There is a huge benefit to using a validated instrument in that from your clinical population, the results of your validated instrument, you can use that to compare your population to other populations. So that's helpful from a research perspective, that's helpful from a public health, overview perspective. However, from a clinical perspective, I get lots of questions from people everywhere, like, what instrument do you recommend? And the bottom line is that the choice of the instrument is far less important than actually having a conversation in a non-judgmental way with your patient. The instrument can serve as a means to have that, or you can have the conversation without that. But the important thing is to talk to patients about substance use. These are some of the reasons people don't share their substance use history with us. We've talked about stigma. We've talked a little bit about CPS involvement. Many pregnant women with substance use disorders have had bad experiences within the healthcare system before. They've been discriminated against, and that comes out. So that needs to be addressed explicitly. And some reasons people don't share is that they don't consider their use to be problematic. So what about urine toxicology? There are, excuse me, I know of many clinics where all they do is they test urine for illicit substances instead of talking to patients about substance use. It's important to know that urine toxicology is a useful adjunct for individuals, especially like through the course of treatment, and maybe monitoring them like in recovery, and certainly is utilized in methadone clinics and stuff like that. But in and of itself, it's not a screening test for substance use disorders, because it just tests whether or not something is in the urine, which doesn't give you a sense at all as to whether or not somebody has problematic use. The window of detection varies greatly by substance. There's lots of things that it doesn't actually pick up, such as most prescription opioids, unless your lab does confirmatory testing. And it's really not going to detect alcohol. It's also important to note that you need to get consent in some capacity for urine toxicology. It was unethical to collect urine to test it for illicit substances amongst pregnant women without their consent. So some of this I haven't really talked about, but I think the audience knows this. Drug use is associated with lots of different diseases. It's costly in society. It's common among women. It's actually, during pregnancy, drug use is more common than many other conditions we routinely screen for. It's universal screening is recommended by tons of different societies. However, it's not as optimally performed as it could be. This was from PRAM's data that only 70% of patients reported being asked about smoking or alcohol during their pregnancy. So providers, when I talk to OBGYN providers, there are lots of reasons why people don't want to talk about substance use with their clients. They don't have time. There's, lots of competing priorities in outpatient OBGYN, as well as in like other, primary care settings. They don't know how to ask. They don't feel like it's their job, and that they're not trained in substance use, in therapy, and counseling. They don't know who to refer to. They don't get paid to do it, or they don't think they get paid to do it. they feel like their patients don't have, these sorts of problems. That's more, I don't know, something in a teaching hospital, something in an inner city environment. Again, stigma and stereotypes. Or they feel like, what's the use? Like, people aren't going to change their behavior anyway. So all of these different reasons that providers don't screen can really be summarized in, the categories of knowledge, skills, and attitude, right? So knowledge about how common substance use is, what are the outcomes of it, knowledge about what are brief interventions, and what are the, the data associated with outcomes associated with brief interventions, skills around how to ask questions, how to deliver brief interventions, and then attitudes, which really speak to, on the negative side, overcoming stigma and stereotype associated with pregnant substance use. So this brings me to SBIRT. I'm assuming everybody knows what SBIRT is, but this is the CSAT definition. It's really a public health approach to delivering early interventions and for people with substance use disorders, and especially those who are at risk of developing these disorders. Think about that pyramid, the people sort of in the middle top part of the pyramid. The thing that I think is really powerful about SBIRT is that it is not, even though it was developed for substance use, it actually is a technique of talking and especially of listening to patients that is useful across a multiplicity of health and illness domains. And so a lot of the skills that I think people learn by learning how to do that, especially the brief intervention part, are useful in many other aspects of clinical care. So SBIRT stands for screening, which is, we've talked about that, how to assess, substance use. It can be patient-administered, provider questions. There's lots of different ways to do it. The brief intervention, which is brief. Really, 3 minutes is really what we talk about. And it's using techniques based on motivational interviewing to sort of increase insight and awareness of substance use in the individual and motivate her towards behavior change. It's really meeting her where she's at and nudging her a little bit. And then there's referral and treatment for those who are identified as actually needing specialty care, i.e. Substance use disorder treatment. Really, SBIRT should be done at annual exams and at all new obstetric visits. And for anyone who screens positive and potentially other subset of people, that should be followed up at subsequent visits. Other people would be people with a prior history of substance use who might, be, in recovery right now, but pregnancy can be a stressful period of time, and some people are at increased risk of relapse, so reassessing where somebody's at is, and you can use SBIRT to do that at subsequent visits. So here's another example of the pyramid and the point that not all use is problematic. And, and it really, the risk depends upon the population. And the goal of the screening is to identify who's at risk. What category do they fit into here? So from looking at this, you can say that most people, when we screen most people, most are going to be in sort of a low-risk group. They're not going to use, or they're going to use at a very low level that we're not concerned about. A handful of people will be in a medium risk level, which for whom a brief intervention is indicated, and only a small subset will actually be at a high risk, meet criteria for a use disorder, and need treatment. So I think sometimes providers get, we're really trained towards this idea of cure. And chronic illnesses in general are harder to conceptualize and deal with. And if you think about use, and certainly use disorders as chronic illnesses, the goal of brief interventions aren't to cure people, but actually to sort of reflect back to them, to raise their awareness of, what the relationship between their use and other medical and behavioral consequences might be, and to actually increase their own internal motivation to change their behavior. So this is just another cartoon that states that of all the people you screen, very few will actually require treatment, and a relatively small amount will actually need a brief intervention. This speaks to the provider concerned with not enough time and what do I do if I find somebody who's using. The truth is that very few of your clients will actually need treatment. And a small group will need a brief intervention, and then everyone else, you just reinforce their abstinent behavior, etc. So how, how do we increase the uptake of SBIRT? Just like with anything, we need to embed it in the standard of care, and that means training everyone, not just providers. Like make everybody aware of it. When we try to change practices in clinical settings, the more buy-in we have across all different types of staff, the more likely that change in practice is going to happen. There's also ways to embed it into the electronic medical record so that it's prompted to ask questions, and the validated instruments can be included into EMRs. And also it can be part of an internal evaluation process for quality metrics. So encourage all of that. The other thing really, there's been too much emphasis on physicians as delivering SBIRT. Physicians are overburdened by time, there's increasing load of screenings, etc., etc. I think we really need to think creatively about staff, about screening, about brief interventions, about who does them actually in order to increase uptake. I'm going to skip ahead to this and go back to that slide. This is this is like a favorite article of mine around SBIRT. It was for smoking cessation amongst pregnant women. And what they did was they actually trained the ultrasonographers to deliver the brief interventions. So as all women now in the United States, most women get a detailed anatomy scan somewhere between 17 and 20 weeks. And that can take 20 or even 30 minutes where all the different little fetal parts are looked at and measured, and the patient's lying on a table, usually with being able to see the ultrasound screen at the same time. And for women who smoke during pregnancy, these researchers trained the ultrasonographers to do brief interventions. To talk to them about smoking, to talk to them a little bit also about like how smoking affects fetal development, etc. At the time of showing them the ultrasound images of the fetus. Unfortunately, they didn't find an effect of this, which is true of a lot of the literature in pregnancy, mostly because most pregnant women quit or cut back. So it's really hard to show a benefit of any additional sort of intervention. And we only measure things like until the time of delivery. And really the point in time where we really should be much more concerned about is how these interventions during pregnancy translate into decreased use postpartum and while parenting. So that's an example of like having somebody else do the intervention, not having it be, on the shoulders of the physician. So ways, the same thing with screening. You can have it computer assisted. It can be the patient. The physician doesn't actually necessarily have to do that. And same with the intervention. We have projects here in Baltimore City where in 2 different emergency departments where there's universal SBIRT happening, and for anyone who screens positive, there's a peer recovery coach who's called, who goes then and sees the patient in the emergency department and delivers the brief intervention. The ER doctors are not doing that, and they are so happy with this system. So this is, thinking creatively about staff and thinking of the staff in the clinic, like every single person who works in the clinic or in the ED or wherever is invested in improving the health of the patients. And even though there's, divisions of labor within all of that, there's some sort of healthcare interventions which can really cut across all of it. And if you've got all the staff involved, there's this echo effect that happens. The person at the front desk, the scheduling, she knows a little bit about substance use and pregnancy and screening and the importance of brief intervention, so she's going to support that, in when somebody asks her a question. Also thinking about alternative staff, like I mentioned, peer networks, and really for people who are thinking of integrating SBIRT into their clinical practice, although generally speaking, consultants can kind of be a bad word. There are some organizations and nonprofits that do a very good job of training and of integrating and of following up with, really bringing this into clinical care. One way physicians change practice is billing for things. There's going to be several slides that follow now. I'm not going into detail on them, but this is all like the information about how you code and bill for things. The downside of where things stand right now is that the time frames. For alcohol and illicit drug use, the time frames are a little bit too long to actually be meaningful, included in primary care screenings. Tobacco, it's a little bit different. There is a billing code for a 3 to 10 minute tobacco use cessation counseling visit. And 3 minutes is really about what we think brief intervention should be. Sometimes they can be a little bit more than that. So this is actually something that is usable and within billing, within clinical care. These are some of the ICD-9 codes that can be used for SBIRT. And if you're interested, there's a lot of other resources available to help clinics and staff figure out how to bill and integrate. These are some examples of it. That SAMHSA website is great, and this is the NIDA one for integrating it into medical care settings. Both of these are really good. This is like the ASSIST, which is a WHO instrument, which is very good. And actually, Wisconsin has a really nice document about coding, billing, reimbursement for SBIRT. In terms of other sorts of trainings, these would be things that staff in clinics could participate in. There's ASAM has a really good one. This is like a free CME and Doctor's Channel. I do not know that one. ACOG has one, and it was developed with the CDC and ACOG, and it's a really a very comprehensive module that's excellent. So this is a real case. The other ones were pieces of real. A 34-year-old who delivered, had delivered in the hospital I used to work at, and her toxicology, because everybody was tested on labor and delivery, was positive for opiates and morphine. Her baby was showing signs of NAS, and I was asked to see her because of this, and she told me she'd been using opioids daily since before she was pregnant. She'd been prescribed them after she was in a motor vehicle accident. Those lapsed. She was developed a disorder. She was doctor shopping for them. Then she was purchasing them illicitly. She hadn't shared this with anyone, with her partner, with nobody. She had a huge shame and guilt around this. She had been seen by one of my colleagues for the entirety of her pregnancy, and nobody had ever talked to her about substance use. And as soon as, but she wanted to talk about it. She wanted to, but nobody ever asked her. So she should have been referred to treatment during pregnancy because she used opioids. She meets criteria for a substance use disorder, or treatment during pregnancy would have prevented neonatal abstinence syndrome. So referral and treatment is the last part of SBIRT. For patients who need the more sort of specialized care, they need specialized treatment. And So when would this be? Somebody who needs maybe detox, and I'm going to put that in quotation marks for right now, or needs a more intensive treatment settings. For somebody who is not responding to a brief intervention, or whose use is like, too severe for that. Or somebody who you want a little bit of extra help with, or somebody that the patient wants some extra help. So the important thing really with referrals is, plan it, warm handoffs, talk to the other provider if possible, have already set up an arrangement where you can share information so that when you see her back for prenatal care, you know what's happening in her drug treatment, and her drug treatment knows what's happening in her prenatal care. It doesn't have to be the physician doing this, but it needs to be sort of a system relationship between domains of care, between prenatal care and substance use disorder. So how do you know who in your community can take care of pregnant women with a substance use disorder? This is a really hard question to answer, unfortunately. SAMHSA has this treatment locator as well as a hotline. This is, when it works, but most of the time they don't have an answer at the level of pregnancy. I would just suggest people, go through their public health authorities, their, state or local jurisdiction health departments, because they might know. Other things are, community-based organizations sometimes know, like NOFAS, and state medical groups, especially ASAM or ACOG, will know the individuals, or not all of them, but they will know some of the people who are identified as being able to take care of pregnant women with substance use disorders. But unfortunately, there's really not a good national clearinghouse. This is the last case. A 24-year-old G3P2, whose first prenatal visit is 26 weeks. She has a history of sexual abuse, prior psychiatric hospitalizations, prior treatment for heroin. She's currently using opioids, benzos, cigarettes, and marijuana. So from this, you see there's a big overlap between what we call co-occurring disorders, right? Overlap between mental health and substance use. And they exacerbate each other, and they're even more commonly overlapped to some extent amongst pregnant women. And the comorbidity of co-occurring disorders, individuals with serious mental illness actually die quite a bit earlier than the rest of the population, and most of that is because of untreated or poorly treated or undertreated medical conditions. This is where, like, some of those facts about co-occurring disorders, about the relationship between behavioral health and somatic health, the observation that people with depression have worse outcomes for their medical illnesses. This is where people started talking about the need for integrated care. And the fact that people with behavioral health conditions or with substance use disorders, they might enter into the medical care system at any point along the way, not exclusively through substance, treatment, and not necessarily through mental health. And for pregnant women, the portal they are most likely to enter the healthcare system is through prenatal care. So what we know about women with substance use disorders who are in treatment is that they are at increased risk of sexually transmitted infections, including HIV. They actually are at increased risk of unintended pregnancies. They have a higher lifetime parity. That means they're pregnant more on average. They have more of their pregnancies are unintended. In this one study, it was about 98% of the pregnancies were unintended amongst women in drug treatment, and they also have more abortions. Related to those, the fact they're less likely to use effective contraception. So this recently came out, and I just suggest you guys, if you want to look at this, it was a really interesting publication that had a nice graphic that I tried to sort of capture here. But it's looking at the SES gradient and pregnancy and all the different pieces along. So if you take 100 women who are, 400% above the poverty line, mid-income, or less than 100% of the poverty level. And you look at how many are sexually active. It's pretty similar across the SES gradient. How many have unprotected sex? Well, poorer women are more likely to have unprotected sex, and middle-income women. How about how many of those episodes of unprotected intercourse lead to pregnancy? Far more likely in the lower SES women than in the higher ones. How many of those pregnancies ended in abortion? Very few of the very poor women. And then how many of those unprotected of these pregnancies go to term? And so you can see across here that there's so when you can see that actually SES, access to birth control, access to effective birth control, and access to abortion services really influences what we see on labor and delivery, which is who's delivering. So it's very important to think about contraception in general, and especially for women with substance use disorders. Probably the best way that we can prevent substance-exposed pregnancies is by increasing the proportion of planned pregnancies in general. And that means increasing access to reproductive health and contraception for women with substance use disorders. That means thinking about drug treatment as a site of reproductive health care delivery. Because basically, when we identify, just like that one case, a newborn with NAS at the time of delivery, and it's really, we're talking about something that unfortunately is kind of like 9 months too late. So that's it. I welcome any questions, etc. And here, this is my contact information in case anybody is interested.
There were a couple of questions that came in when people registered, and I think you have those.
Yes, I do have them.
And then I have a couple of other questions after you've gone through those.
You want me to go through these?
Sure, yes.
All right. Question 1 was, what is the best way to educate the medical community about the benefits of methadone for an opiate-addicted client? So I think that this question sort of speaks to the stigma that can be associated with methadone in general as a treatment, or actually any medication-assisted treatment. But what we know is, and this will, there's another question coming up about detox, but what we know, so we do not recommend detox for opioids during pregnancy, because you can definitely detox somebody off of opioids, i.e. get them to be abstinent from opioids after 5 or 7 days, but we know that people who go through that are more likely to return to illicit drug use by the time of delivery. And they're also, although there's not as strong evidence for this, like by returning to illicit drug use, also putting themselves and their fetus at risk of sexually transmitted infections, especially, HIV and Hep C. Not sexually transmitted, HIV and Hep C injection related. So the way you educate the medical community is by disseminating, actually this is like a knowledge deficit to a large extent, disseminating knowledge, but it's also an attitudes intervention that that medication-assisted treatment is needed not just in pregnancy, but should be offered to all opioid-dependent individuals. I'm not sure if I'm answering that question correctly, but I think it's just education. The next question is, how does epigenetics interact with substances to affect fetal development? I don't know the answer to that. I do know that there is some recent data looking at variants in the opioid receptor that genetically related that seem to influence the severity of NAS in newborns, but exactly what the epigenetic part of that is, I do not know. The third question was, what is the most recent information regarding effects of substance use on the newborn, including effects of early intervention? There is more data on tobacco and alcohol than on illicit substances, but generally speaking, alcohol is the leading cause of mental effects in newborns in the United States. There's the whole fetal alcohol spectrum disorders. Cigarettes are associated with low birth weight or early deliveries and their subsequent sequelae. What we're learning a lot more about is how the sort of fetal environment influences chronic disease development in adults, and the sort of chronically hypoxic environment from tobacco smoke seems to increase other health likelihoods in adults. The literature for illicit substances is not as developed, and honestly they are, except in sort of catastrophic situations like a placental abruption from an acute cocaine intoxication, illicit substances are, generally speaking, less harmful. Alcohol is a teratogen, i.e. causes birth defects, and none of the illicit substances are. The effects of early intervention, so SBIRT is an early intervention during pregnancy, but I think maybe what the question is getting at is early intervention after birth for newborns. And really the data for that are much more from alcohol than from any other substance, but we know individuals, newborns who are identified as being alcohol exposed and on some sort of an FASD spectrum who get early intervention compared to those who don't do better developmentally and cognitively. The tricky thing is figuring out who those newborns are. The last question is, what are your recommendations addressing pain management during and following delivery, and also for detox? So I will share an article with everybody that Andre was the first author on, that came out of a work group at the CDC that I participated in with her, on that directly addresses pain management for opioid-dependent pregnant women during labor and delivery. The big picture is that do not withhold pain medicine from somebody because they're opioid dependent. They might need more pain medicine. Regional anesthesia is best. You want to, if they're on MAT, you want to maintain them on it throughout the course of their labor and delivery. This final part is like my recommendations about detoxing pregnant women from benzodiazepines. Benzos are just horrible, like bane of my existence to sometimes. They're oftentimes co-prescribed for people in methadone. They're just, I wish there were a lot fewer benzos. I recently was helping to take care of somebody who was in benzo detox. My big picture about detox is that, just like I mentioned for opioids, it really doesn't work for the long term. And certainly it doesn't work as a standalone treatment entity. It needs to be, it makes sense if it's linked to another level of care. So if somebody comes in to treatment on both opioids and benzos, and in order to be initiated on the methadone or maintained in the methadone clinic, she needs to be abstinent from the benzos. Well, then maybe we put her on a detox and then give her the methadone at the same time, and then have her continue in a high level of care for the methadone. But generally speaking, people relapse because all you're doing is sort of treating the dependence, but not at all treating the addiction. I'm not really, I could talk for hours about all these problems with that, but I'm going to leave that at that.
Great. There were, before we open it up and see if there are any other questions, there were a couple of emails that came through wanting some clarification on a couple of things, and one had to do with, I think it was a slide 50, where it says treatment during pregnancy would have prevented neonatal abstinence syndrome.
Oh, yeah.
And that wouldn't be true if the mother was receiving medication-assisted treatment,
Correct.
right?
Correct.
Okay. Yeah, we just wanted to clarify because it would mean that she might avoid poor birth outcomes, but not, the baby still might demonstrate neonatal abstinence syndrome during that
Correct.
time. Okay, good. And then there was another one, and this pertains to the risk pyramid, and certainly understanding that largest category, that low risk level, is not as much of a concern about somebody's use. That wouldn't also extend to pregnancy, though, would it? I mean,
that's a great. I had that question on my slide, and I didn't answer it, and I put that as a question out there. What does this pyramid look like in pregnancy? And I would argue, I would say that actually it's not. It's the bottom of the pyramid. It would be abstinence, and you can. Because that's the recommendation, right? For alcohol, for illicit drugs, even, for cigarettes. So, but, this is a whole nother big topic of conversation. Is rare alcohol consumption during pregnancy truly harmful or not? So, I'm not, so I would say, it's, but generally speaking, yeah, the pyramid looks a little different for pregnancy. It's mostly going to be abstinent in the bottom rather than low risk.
Right, and looking at the concerns for both the mother and the fetus. Yes.
Correct.
Okay. Jonathan, can we open up the mics to see if there are any other questions, or how do you want to do that?
We can try, but there's usually some type.
We didn't see anything else coming through on the chat log.
No, I don't see anything.
Okay. What we can also offer is that
there was a question from in the question log. Did you see that one from Debbie?
I did not. I did not. You want to go ahead and read it?
There's a higher risk of miscarriage if a pregnant woman is detoxed off of opioids.
Yeah. Yes. Honestly, like, the main concern is going to be relapse. And that's why, so historically there was some evidence to show an increase in miscarriage, and so that's why people would only detox in certain periods of time. But those data aren't super strong.
Okay. Well, I think we'll, if there are other questions from the audience, certainly please email them to the IDTA email, send them to your individual change leaders, and we'll get answers for you on that. We'll go back to Dr. Terplan on that, and in instances where you have a question that maybe he can't answer because it's sort of out of his scope of practice, then we'll look at that and see where else we can get one. I would really appreciate if you would complete the brief evaluation at the end of the webinar. It really helps us. It'll allow us to go back to him and provide feedback. I also want to remind you that our next webinar will be on April 2nd at this next time. And Dr. Terplan, I can't thank you enough for this presentation and all the information that you've provided.
Well, thank you so much for having me.
Thanks to all of you, and please stay safe in that weather that you're all having.
All right.
Bye.
Bye-bye.
Thank you. Bye-bye.